Hello, everybody. My name is Walter Klepetko from the Medical University of Vienna, and I'm very glad to have the opportunity to give you this lecture on the recent developments in lung transplantation. As you know, lung transplantation certainly is a meanwhile very important option for a highly selected group of even PH patients. And I think, therefore, it's very important that patients get basic information where we are with lung transplantation in the year 2021, and also what has been achieved and brought forward during the recent years. So basically, my talk will include some considerations about the position of lung transplantation, frequency, the outcome, the medication, the quality of life, and the life expectancy, and the details that really have been so fascinating in the recent past, which really have improved the results of lung transplantation significantly. This is what it's all about, the big problem. Pulmonary hypertension means that the resistance in the pulmonary circulation is increased, and as a matter of fact, the right heart is failing and is getting enlarged. And you can see here on the left side this huge heart, and on the right side you see a typical echocardiography where you can see that this is the right ventricle, very much enlarged. The septum is going to the left, and the left ventricle is compressed. And this is what is making the symptoms to the patient, especially in such an advanced stage of the disease. Now, for those patients who were not accessible for any medical therapy, and when we look back in the 1980s, certainly medical therapy was also very much in its beginning as surgery was. The surgical solution or answer to this was a combined heart-lung transplantation, which was introduced in Stanford by Norman Shumway and Bruce Wright in the year '89 for patients with pulmonary vascular disease. However, very soon, the medical community realized that it's not necessary to transplant the heart in this situation because the heart will improve anyway. It's just about the lungs. And several groups, including our own group, early on proposed results from simple transplantation of the lungs without transplantation of the heart, with very good results already. So what does lung transplantation, isolated lung transplantation, do? It normalizes the resistance in the pulmonary vasculature. As a matter of fact, the right heart can recover and can regain its original shape and dimensions. And this is simple thoracic X-ray of one and the same patient. You see the heart before and the heart after transplantation, and this is a few days after transplantation, and you see how dramatically the size of the heart reshapes. And this is the pathophysiological background why isolated lung transplantation is working for pulmonary hypertension. To give you a proof that this is not just happened in this case, these are random 8 pictures from 8 different patients with advanced PH. And on the left side, you always see the heart before the transplant and after, before the transplant, after, before the transplant, after, before the transplant, after. And automatically you see there's a huge, huge change and huge difference. And this explains the gain in functional capacity and also the improvement in the functional performance of the patients. Now, what does lung transplantation mean worldwide? This is data from the International Society for Heart-Lung Transplantation, the registry, and you can see approximately about 4,000 procedures per year entering the registry. Certainly, there are a number of procedures out there above that which are not recorded here, but this gives quite a good information already. In our own cohort of patients in Vienna, and we have done more than 2,200 procedures meanwhile, idiopathic pulmonary hypertension is about 7% of all the indications for lung transplantation. Certainly not the most frequent indication. However, a very important indication. And the next question that is arising, certainly, what are the results that we can expect from lung transplantation? And there has been significant progress over the years. When we look back at the registry data from the very early years in blue, then in green, and then in red, there is a clear improvement over the years. But the results that we are facing nowadays are even better in experienced, selected institutions. These are data from our own group, and you can see in the recent cohort of patients after the years 2010, there is a very, very flat survival curve in those patients, giving evidence that the outcome has dramatically improved with all the knowledge that we have got over the years. These are data for all lung transplantations. And these are the data for the last years, 16 to 20. Again, you can see we are very high up at the 5-year survival, up to 70%, and 1-year survival rates of approximately up to 90%. The perioperative mortality of our patients, which means 90-day mortality, has nicely decreased down to about 3%, 2 to 3% mortality in the last years, which is also giving evidence that lung transplantation has become a quite safe procedure. Even more important, if we look at the selected group of PH patients, not all indications, just the PH indications, these are from our last publication that we have given out in the year 2018. And you can see this is the most recent cohort here with extremely good long-term outcome, even better than in the overall population of patients with lung transplantation. And the background to this is that usually patients with pulmonary hypertension, once they are through the transplant procedure, they do face a much better postoperative survival curve as compared to, let's say, COPD patients who have a lot of comorbidities normally, a lot of steroid therapy before in the past, which contributes to the problems that are arising in this population postoperatively. So the message is PH patients are in a good cohort of patients when we are talking about the outcome and the long-term outcome after lung transplantation. And these data from our institution are pretty much similar to what experienced other groups. Here's an example of the Hanover group that's published. They are almost identical outcome as you can see here on the figures here on the right side. But the question is, what is the benefit of lung transplantation? Is it only survival? Is it only outcome? Or is there something else? And yes, of course, there's something extremely important else beyond outcome. This is quality of life. And if we are talking about quality of life, we have to question ourselves, what kind of activities were the patients able to do before the transplant procedure and after the transplant procedure? And this is a cohort of 100 patients, not only PH patients, different indication, 100 patients which were questioned about what they could do before and thereafter. And you can see all the red ones means not possible. Hobbies, shopping, stair climbing, walking, in a very, very high percentage, not possible in our patients. And green means possible in a very low percentage before the transplant procedure. And this is after 1 year after lung transplantation. And you see all the green bars here, what became possible to the patients after a successful lung transplantation. So these are very nice data giving evidence about the quality of life that you can achieve. And there are some individual examples which even better underline these results. This is just a photo of one of our patients sending us from his hobby that he is now able to do again, which was, of course, he was completely unable to do before. And this is something that we did 3 years ago. We wanted to give a very strong statement about what people after lung transplantation can achieve. And our group decided we would like to go with 10 of our lung transplantations to the summit of the Kilimanjaro. And here we are at the summit of altitude of about 6,000 meters. And you can nicely see here the flag of PH Europe here at this altitude, held up by our patient, Italian patient, who was among the group of the 10 lung transplant patients. And this is the very proud group all together up there on the summit, celebrating this really, I would say, impressive achievement that we all were able to get. We even made it in the Times with this. And I think that's also a very positive and strong message to the patients that what can be possible if you have a strong will and you really think positively in your life. But let's talk about the factors that have contributed that the results have improved over the recent 5 years. Factor number one, this certainly is timing of the procedure. If we look back in the year 2009 at the recommendations of the European Society, you will find lung transplantation at the very low end, at the left lower corner of the algorithm how to treat PH patients. And certainly, lung transplantation should never be a procedure which should be reserved in the last minute, because then the problems are really huge. It should be a well-planned procedure. Not too early, not too late. And getting this knowledge results from the understanding of the vicious circle of lung transplantation, especially for PH patients. Late referral for lung transplantation means that there is an increased perioperative morbidity, which results also in an increased perioperative mortality. And the quality of life for the patient in this period of time is sometimes really, really very terrible. So the outcomes with this referral procedure are really unsatisfying. And then people in the past said, okay, there's not a good outcome. We refer the patients even later for lung transplantation. And the circle was going on and on and on. And luckily, we were able to interrupt the circle by a better understanding that it needs a good timing for lung transplantation. And in the year 2015, the European societies recommended that a referral for lung transplantation should be considered earlier on, after an inadequate clinical response of a double medication therapy already. And with this thinking, the treating institutions and groups started to think about the possibility of lung transplantation at a much better point of time. And as a consequence, patients came to transplantation in a much better shape. And again, the year 2019, the algorithm has even found more precision out of that. So we now have a better understanding. What are the risk factors for patients to die? There are the low risk group, there's the intermediate risk group, and there is the high risk group. And there are the typical clinical signs for these three different groups. And by better understanding, better analyzing, we automatically can better group our patients into the individual risk group and have a better expectation for their life expectancy. So what we don't want to see again nowadays is patients that we have seen in the past with extremely advanced forms of pulmonary hypertension, with severe ascites, with severe edema, under full drug therapy, completely bedridden. These patients have faced, of course, enormous comorbidities and also high mortalities during the transplant procedures. But if you avoid this advanced status, then the transplant procedure can be performed in a much more safe and easier way. So what are the considerations for decision-making? Number one, there is a type of disease. Is it an idiopathic pulmonary hypertension? Is it a pulmonary venous occlusive disease? They have a different prognosis. You need to react in a different way. The response to therapy, crucially important. Patients who are running very well on therapy, they are not at all candidates for lung transplantation. But if there is no response to adequate double or triple therapy, you have to think about this possibility. And then the expected waiting time in an individual center. Some centers have an expected waiting time of 3 months, others have of 2 years. You have to keep that in mind when you want to refer your patient in due time. And finally, of course, you have to compare the expected results that are provided versus the results that are provided by the medical therapy. So the close cooperation of a transplant center with the PH center and including the patient in the discussion is a crucial strategy for achieving a good success. What else has contributed to improve the results? Organ availability. There has been many changes in the past. The legislation has been adapted in many countries. The donor criteria have been extended. We know now we can also accept some donors where not all parameters are perfectly well. An active donor management has been introduced. That means a donor is not a dead person who is lying there. It is still a person who needs an active management and therapy to provide good quality of organs for the harvesting procedure. The introduction of size-reduced lung transplantation, that we can use bigger lungs for smaller recipients, meaning lobar transplantation is none of them. The introduction of living donation, where you're using lobes from bigger adults, which are from relatives, which are donated for their relatives for transplantation. The understanding that non-heart beating donation is possible, the so-called ex vivo reconditioning of lungs who are not adequately performing, all that has contributed to a huge improvement and increasing of the donor pool. So this is an example for lobar lung transplantation. You must not necessarily take all the lung. You can use one lobe, a lower lobe or upper lobe, depending on the size and everything. And there are different indications for that. If you have a pathology in one lobe, you still can use the other lobe. If you have an unexpectedly large donor, you can downsize the lung. Or if you have an urgent recipient with a small chest, you can go by intention for a lobar transplantation. These are some examples. These are father and mother and the child received 2 lobes from its parents. Another example, a young lady here, again, bedridden, is unable to get out of the bed for weeks and even months, and the parents willing to donate a lower lobe each. And you can see the family 4 or 5 years later, and you can see how nicely the girl has performed, how it has grown up and has become a charming young lady with an excellent quality of life. And also is still the life quality for both of the parents is excellent, despite the fact that they have donated lower lobes to the daughter. And sometimes even an extreme case, this is a young 14, 15-year-old girl, which comes in a last second already on an ECMO bridging, on a pump device, coming with the parents willing to donate. We have evaluated the situation. We have found no contraindication, have then done the bilateral lobar transplantation. And this is the family a month later when they return back home with their daughter in very good shape. So these are examples that even a donation of lungs is possible and is a meaningful possibility. Also, it is not so frequently used in our area here. It's more used in the Japanese area, where cadaveric donation is not part of the religion and not part of the philosophy there. Another point which has helped to expand the number of available organs certainly is ex vivo lung perfusion. And you can see here such an example. This is a lung harvested where the performance of the lung, the parameters were not ideal. So the lung is put on a circulation circuit. It's been perfused for several hours. It's ventilated. And during that period of time, it is recovered. It is improved in its quality. The fluid is taken out of the lung, and then the lung can be used for transplantation. And we have introduced that in our institution nicely many years ago already as well. And this is meanwhile a very unspectacular procedure. You can see here the lung here in the OR, and except of one nurse who is taking care of the lung during the perfusion, no one else is there anymore. Whereas in the beginning, tens of people were standing around and watching and observing this. So this has become routine in many departments and has helped to use lungs which otherwise would not have been safe enough for implantation. Another factor which has helped to improve the results is our handling of the high urgent patient, the patient in the last second. You have seen the girl here on the ECMO, and this is another example for this. In those situations where we are really coming under pressure, we are really having only few weeks or sometimes days time to find a suitable lung, and the patient is in a very critical advanced situation, bridging with ECMO is a very, very helpful procedure. And you can see the bridging with ECMO is meanwhile does not mean that the patient is completely sedated. On the contrary, this is a patient who is not intubated, is on this pump. You can see her here in the bed, and she's training here with the bed cycle and on her computer at the same time. And in that way, waiting until a suitable lung becomes available. So APHEC, so-called ambulatory bridging, is a very important tool in our hands meanwhile. It avoids the deleterious effect of mechanical ventilation and sedation. It allows to mobilize the patient. It reduces the need for medication, and it improves organ functions. And you can see here...
So I'm looking forward to the operation to get a new lung, which will give me a better life quality and a future for my life.
So you see here two examples of patients on ECMO waiting for the lungs, the one on the treadmill, the other one in the bed, but fully awake and really in good shape, but also in good spirit to go ahead with that. So we are not talking about bridging only, we are meanwhile talking about bridging and improving our patients by improving the renal function, the fluid balance, the physical mobility, weaning them from medication and from ventilation during the waiting period for a lung. Another step forward that we were able to make in the recent past was a better understanding how to protect the lung during transplantation and to guarantee a good organ function after the transplant procedure. And the key to that was the understanding that intraoperative ECMO support is really crucially to provide the lung a very, very smooth ride through the transplantation. First, we have given proof for that in a retrospective study where we compared patients who were transplanted on ECMO in green to the other cohorts without ECMO and with prolonged ECMO. And it was nicely came out that the patients transplanted on ECMO had a better outcome. So what you see on the left side, white lungs after transplant procedure were really damaged. This is history. You don't see this almost in less than 1% of your patients anymore. What you see now immediately after transplant procedure is a perfectly well functioning lung, which presents in the black, transparent way on the thoracic X-ray. And the data from our department in a prospective study showed very nicely that after 72 hours, meaning 3 days, almost 3/4 of the patients are extubated. The function of the remaining not extubated patient, the function of the lung is very good. And there are no PGD3, so-called PGD3 lungs, which have an unsatisfying function. So you can really avoid all the damage to the lung with that kind of handling of the lungs. All that together allowed us to bring the field of lung transplantation forward. We now have included pediatric lung transplantation also in the transplant procedures. This is an example of the smallest lung that was ever transplanted in our institution. This is an example of a sweet little girl with pulmonary hypertension. I think the girl was about 8 years old immediately after the transplant procedure, a few days thereafter. So it shows what can be done nowadays when you have fine-tuned many different parts of the handling procedures. And one very important part certainly is also to find the right balance in immunosuppression. Over the years, there have been an achievement by introducing different types of immunosuppressants. And with these different types of immunosuppressant and finding individual so-called patient-tailored medication combinations, we now have a bigger armamentarium of drugs to deal with rejection. And the balance between rejection and drug toxicity, infections and malignancies is now better to be achieved by the treating team. These data, I have to admit, they are from kidney transplantation, but they are very similar for lung transplantation as well. They are showing very well that over this long period of time, the acute rejection incidence has come down dramatically, whereas the one-year graft survival has also increased dramatically. And this is the benefit of all these little steps that we were able to take over the past centuries, not only in lung transplantation, but also in transplantation of other organs. But we are certainly still facing limitations of immunosuppressive therapy. This is sometimes patient compliance and adherence. It's very important for a patient to stick to the therapy very precisely. We are not able to heal patients with transplantation. We are able to give them much better quality of life, and we are also able to give them much better life expectancy. But they are still remaining so-called there are still remaining patients which need a close follow-up and a good adherence. There are negative side effects from the long-term exposure to immunosuppressive therapy, of course. There is long-term comorbidities induced by these agents. There is a need to continue the agents for lifelong. And there is, unfortunately, our inability so far to induce a complete tolerance to the organs, which would mean that you don't need any immunosuppressive drugs anymore. This is something where we are still working on and hopefully will achieve somewhere in the future. And that way, this is the balance between over-immunosuppression and under-immunosuppression that you have to find for your patients. But in general, I think, or I hope I was able to give you some idea that lung transplantation came from being a very risky drive, like driving with a car here on this Himalayan mountain highway, to a smooth ride on a camel. And on the right side, you see more or less 2 lung transplant patients, because this is the mother who gave birth to this child 1.5 years after having her transplant procedure. And the child has nicely grown up, as you can see here, and they are enjoying here their life in a very, very nice way. So since our institution in Vienna has created a lot of interest in teaching and other institutions as well, we are running this Lung Transplant Academy here in our institution, and we are very happy and proud to have participants from all over the world here coming to get structured lectures, to have a full clinical involvement, and to learn what lung transplantation can be in the year 2021 and what it can offer to the patients. And this is the team I'm very proud about to work with. And on behalf of the team, I think I was also speaking to you in this lecture. I hope I was able to transfer to you the message that lung transplantation has become a very important and very valuable option for PH patients. This is not for every PH patient. It's for a selected group of patients, and it's crucially important to do the selection procedure in the right way. And important for that is to find the right selection, the right timing, and the right performance in a close cooperation between the patient, the PH center, and the transplant center. Thank you so much for listening to this, and hopefully hear you on the question and answer session in March 2021. Thank you very much.